Bernard-Soulier syndrome as well as Glanzmann thrombasthenia belongs to a so-called platelets disorders. They are very similar in certain aspects. They both are rare inherited blood clotting disorders. They both are caused by autosomal recessive mutation. In both cases, mutation affects the receptors that are present on a platelet surface. They both affect primary hemostasis, thereby they both have the similar clinical presentation and treatment. But the major difference between these two disorders is the receptor that is affected by the mutation and also the step in primary hemostasis that they disrupt. To explain the pathogenesis of these disorders, we have to recall the major steps in hemostasis. So, if damage to endothelial cell occurs, endothelium that was contained inside the endothelial cell will be released into the bloodstream and will cause transient vasoconstriction. After vasoconstriction, organism has to immediately cover and repair the damaged area. In order to do this, endothelial cells release from Weibel Palade bodies huge amount of von Willebrand factor. In the bloodstream, von Willebrand factor binds to subendothelial collagen under the disrupted endothelial cell. After that, platelets come to the site of injury and by the specific receptor GP1B, they bind to von Willebrand factor, and exactly this simple step called platelets adhesion. After the adhesion, platelets become activated. In response to this, they undergo shape change that results in their degranulation. With degranulation, platelets release the content inside them, including the dense granules that contain ADP. ADP that is released into the blood acts on ADP receptor on platelets and activates it. Activation of ADP receptor forces platelets to transport GP2B3A receptor to the surface, where GP2B3A serves as binding site for fibrinogen. In addition to this, platelets from prostaglandins by COX enzyme begin to produce thromboxane A2, and the function of thromboxane A2 is to promote aggregation. When fibrinogen notices a GP2B3A receptor on platelet surface, fibrinogen immediately binds to GP2B3A, and when another platelet comes to the site of injury, platelet immediately binds by GP2B3A to fibrinogen, and this process is significantly accelerated by thromboxane A2. This binding occurs over and over again until platelet plaque will be formed, and exactly this gathering of platelets at the site of injury called aggregation, and aggregation results in formation of a platelet plaque. But platelet plaque is weak, and to stabilize it, to make it formidable, we have secondary hemostasis. The function of the secondary hemostasis is to make from weak platelet plaque a formidable structure that's called thrombus, and the thing that makes this platelet plaque formidable is conversion of unstable fibrinogen into a stable fibrin. Secondary hemostasis is provided by coagulation factors that form coagulation cascade. The central factor of coagulation cascade is factor 10. The goal of both intrinsic and extrinsic coagulation pathways is to activate factor 10. Intrinsic pathway consists of factors from 12 to 8. Extrinsic pathway consists of just factor 7. Activation of factor 10 results in activation of factors 5, 2 and 1. Factor 2 called prothrombin that with activation becomes thrombin, and factor 1 called fibrinogen that with activation becomes fibrin. And exactly fibrin makes from platelet plaque a formidable thrombus. So secondary hemostasis converts platelet plaque into a thrombus. To assess the extrinsic pathway, we use prothrombin time and international normalized ratio. For assessment of intrinsic pathway, we use partial thromboplastin time. Bernard-Soulier syndrome is a condition when due to autosomal recessive mutation, the GP1B receptor on a platelet surface becomes broken. As a result, adhesion becomes impossible, and thereby primary hemostasis becomes disrupted. So, as we see, after von Willebrand factor binds to subendothelial collagen, platelet has to bind to von Willebrand factor by GP1B receptor. But in Bernard-Soulier syndrome, GP1B receptor is broken, thereby platelet cannot bind to the site of injury. So adhesion becomes impossible. Without platelets adhesion, platelets cannot be activated. Without activation, they cannot release ADP into the circulation, and thereby they cannot force transportation of Gp2b3 receptor into the platelet surface. So fibrinogen cannot bind to platelets. As a result, platelet plaque cannot be formed. So primary hemostasis becomes dysfunctional. And dysfunction of the primary hemostasis manifests with prolongation of the bleeding time. So Bernard-Soulier syndrome disrupts platelets adhesion, and this manifests with prolongation of the bleeding time. In addition to this, disrupted adhesion can be diagnosed with abnormal aristocytine test. Glanzmann thrombasthenia is a condition when due to autosomal recessive mutation, the Gp2b3 receptor on a platelet surface produces broken. Production of a pathological Gp2b3 receptor disrupts aggregation of platelets, thereby affecting primary hemostasis that cause prolongation of the bleeding time. So what happens in Glanzmann thrombasthenia is that as a result of a mutation, Gp2b3 receptor becomes broken. As a result, fibrinogen cannot bind to platelet, and obviously without fibrinogen, platelets cannot be connected. So in Glanzmann thrombasthenia, platelet-to-platelet aggregation becomes impossible, thereby platelet plaque cannot be formed. So primary hemostasis becomes totally dysfunctional, and dysfunction of the primary hemostasis manifests with prolongation of the bleeding time. In addition to this, on a blood smear there will be no platelet clumping, because as we know in normal condition on a blood smear, some platelets by Gp2b3 receptor and fibrinogen can bind to another platelet, and phenomenon when two platelets are binded together called platelet clumping. But in this case, because Gp2b3 receptor is broken, fibrinogen cannot bind these two platelets, so there will be no platelet clumping at all. So as we see, the major difference between these two disorders is the stage of a primary hemostasis that they disrupt. Bernard-Soulier syndrome disrupts platelet adhesion. Glanzmann thrombasthenia disrupts platelet aggregation, but everything else is similar. Because both disorders disrupt primary hemostasis, they manifest with typical so-called mucosal type of bleeding. First of all, they all have prolonged bleeding time. So in routine life, after cuts for example, bleeding lasts longer than normal. The major feature is that they have mucous membrane bleeding, primarily from GI tract. They have bleeding gums and nose bleeding, so-called epistaxis. Also, disruption of a primary hemostasis causes microhemorrhages that on the skin manifest with petechia purpura ecchymosis. Also important that in both disorders, platelet count is normal. The problem here is the production of a pathological receptors on a platelet surface, but not in the production of platelets in general. Also very important that secondary hemostasis is not affected at all, and because of that, prothrombin time, international normalized ratio and partial thromboplastin time will be completely normal. The treatment is also the same for both disorders. The major treatment is platelets transfusion. Also we can use tranexamic acid. If you like content, please press like and subscribe button. All the best!